study that was published recently where this was in patients with knee osteoarthritis, and they did culture expanded stem cells. So they took the stem cells, grew them in a lab into, 20, 30 million cells, and then injected those back in. What they were comparing was culture expanded mesenchymal stem cells that were autologous, so they came from the same patient, versus allogeneic, so they came from a donor, somebody else. And what they showed was that when you get your own cells back, you get better outcomes. And so there's something about your body, either it's your body recognizing it's your own so that it does better when it's, the stem cells are doing its work. But we also know that there is a level of rejection that happens when other cells get put into you. The cells, for the most part, kind of can evade the immune system a little bit, but a lot of those cells, when they come from another human, still get cleared out by our immune system because our body, to a degree, recognizes, hey, these are not my own. I should start clearing these out. The same way, if you get an organ from somebody, your body wants to reject it, even if it's perfectly matched, because it recognizes it's not my own. And so that just goes back to the question on, okay, do you want to use your own cells or do you want to use somebody else's cells? Well, we've got some data here that says like, hey, maybe your own cells are actually going to do better.
Thank you for listening to the Generational Health Podcast. Today, I had the opportunity to sit down with Dr. Drew Timmermans. He's an expert in all things longevity, peptide treatments, and stem cell type treatments, PRP. We had an awesome conversation about all these different therapies that people can take advantage of if they're dealing with pain or just lingering issues. So I think you'll find this really interesting if you have any interest in stem cell therapy, PRP, the difference between the two. He also talked a bit about different new therapies of injections to help release nerve issues and other pain that can be coming from various nerve problems. So I think you'll really enjoy it. And again, want to thank Hiva Health, who is our sponsor in making this possible. You can check them out at www.hivahealth.com. They offer a wide range of wellness therapies for medical weight loss, hormone replacement, and general longevity. Again, thanks for listening. Dr. Timmermans, thanks for coming in to the podcast.
Colby, thanks for having me.
Yeah, just came right in and we're just getting right to it.
Rock and roll.
I know you're on a schedule. You got another meeting after this, so we'll just get rolling. Hey, thanks for being willing to come in here. I know you're busy. We were just saying I met you several years ago at the gym. I was wearing a t-shirt from Strive Pharmacy. Those guys are my really close friends. I love those guys. And this was like early on because they've only been around for maybe I think they hit 7 years. I'll have to check. This was maybe like 6 years ago. I was wearing one of their first cut Strive shirts with their old logo. The white with just the blue logo. That's probably That's probably what it was. And you pulled me aside and you're like, hey, do you work at Strive? And I was like, no, I don't, but they're friends of mine. And you were like, oh, I've worked with them. And anyway, so then I started following you on Instagram and you just come out with all sorts of really interesting, cool information, specifically around all these kind of regenerative medication treatments and injections and all the injectables that you can do to try to regenerate versus, just getting straight into replacements. Mm-hmm. So I think there's going to be some really cool stuff in here. So we can talk through all that. But before we do, we'd love for you just to introduce yourself, maybe tell us, let the audience know where you came from and how you got here and why you enjoy doing what you're doing, what got you into this in the first place. And we'll just go from there.
It's a good story. So I'm a naturopathic physician. So in high school, I realized that I wanted to be a physician. I grew up in Canada, Southwestern Ontario specifically. And up in Canada, there's really just MDs. There isn't DOs. Like that's not a path you can take to do conventional medicine up in Canada. There are DOs, but they're like European trained, like more your like visceral therapist type stuff, but they're not regulated the same as they are in the States. And naturopathic medicine just wasn't really on my radar. And so my plan was to go through allopathic school. At first, I wanted to do cardiothoracic surgery. Went and shadowed and observed an open heart surgery. And one of the most amazing things I've ever seen in my life, but it didn't get me going. So I was like, okay, that one's not for me. And I had a sports background, ran track and stuff like that. And so eventually through college, I kind of decided I was going to do sports medicine or orthopedics. So after undergrad up in Canada, I applied to med school, did my MCATs, everything that they need done. And I didn't get accepted. And so I went and worked as a personal trainer for a year while I was beefing up the weak parts of my resume to reapply. And obviously, as a personal trainer, I'm working with clients and I'm helping them lose weight and feel better and get off medications and all this stuff. And one of my clients noticed that, like, I got really excited telling her about other clients getting off of blood pressure meds, off statins and all this other stuff just by the dietary and exercise stuff we were doing. And she's like, hey, have you ever thought about doing naturopathic medicine? I'm like, I have no idea what that is. So went home, researched it. And there's like 6 core principles of naturopathic medicine. But the core ones that like really resonate with me is like, is stimulating the body to heal itself and utilizing the power of nature. And like those 2 things, just in my core, that was my own philosophy of medicine. I never vocalized that. But as soon as I read it, I was just like, that's me, not surgery and not drugs and all this stuff. Like, this is me. So changed trajectory. My mom was not happy. Changed trajectory and then started researching naturopathic med schools. At that time, there was only 7 across the US and Canada. There's Toronto, Vancouver, and then a bunch through the States. And just started applying, had interviews. And within 6 months, I had packed my bags and I drove my 2004 Volkswagen Passat from Canada to Arizona. And then so I got here. Well, right before I moved out, I was in a car accident where I ended up herniating 2 discs. And so that started me on a long path of having my own chronic pain. And I had tried a bunch of different things. I didn't do steroids. I didn't do surgery because, again, it wasn't like I was trying to do everything except for that. And I almost didn't come to med school because I was really afraid of the long drive, because sitting and driving would just kill my back. Pain would go down the leg. Like it sucked. So thankfully, I made it out. In second year med school, I went to a sports medicine conference out in Florida. And at that conference, got exposed really I knew about like prolotherapy and PRP and stuff like that. But this was like the first conference that I went to that's all they did. And so learned about kind of that side of medicine. And then at the conference, there were some demonstrations, and there was a doc who was the president of the association at the time. He was doing an ultrasound demo, and he's like, hey, anyone got any low back pain that like no one can figure out? And I'm like, me, right? Because no one could really figure out why I was having back pain at that point. So he does an exam on me and then does a diagnostic ultrasound and finds a tear in my iliolumbar ligament, which is a ligament in the low back, and then in my thoracolumbar fascia, which is that big piece of fascia that connects your lats down to your low back. And the next day, he approaches me. He's just like, hey, we're doing a demo for one of the PRP kits. Can I treat what I found yesterday on the ultrasound? And I was like, yeah, sure. So at the conference, I got my first PRP injection. And for the first time, and then 3 months later, for the first time in 2 years, I was 100% pain-free. And so that experience just solidified. And I was like, that's what I want to do for the rest of my life.
Man, that's cool. Like, that is so cool. I personally know a lot of people that are dealing with a lot of chronic pain. And there's a ton of people now that are kind of waking up to the fact that you don't need to jump straight into surgery. And there's a lot of things you can do before that. Because I think the other thing too, maybe we can talk about, is just some of the trade-offs, right? Like if you go in and get like a, what do they call it when you get the steroid injection?
Like an epidural for your back?
Well, that, or like just to kind of like ease the pain for some time, cortisol.
Oh yeah,
like a cortisol injection, or cortisone. Is it cortisone?
Yeah.
Sorry, cortisone injections where people go in and get that done. But to my knowledge, over time that can weaken your ligaments if you do that too much. It's not really it's sort of a Band-Aid, not a solution to have your body repair itself. And so people are looking for ways to avoid surgery. And so I think this will be super helpful information. I know personally in my life, family members that have had to have, shoulder replacements or hip replacements, and even just like and maybe there's a spot for this too. I'll be interested to ask you about it, but like, the healing journey there, it's not always, some people come out of a hip replacement and they're walking like within a couple of days and they're fine and they heal and everything's great. Others that I have seen personally really close in my life have had to go back in for second surgeries. They're walking disjointed. It's causing pain in other parts of their body. So even like healing from some of these maybe surgeries that were required, I think it would be cool to see if are there treatments that could be done to help them heal better as well after post-surgery. But anyway, I think your form of medicine is really fascinating and really cool. And there's a lot of fun stuff in the stem cell space. And maybe before we get into kind of a couple topics I've written down here, because this is kind of a foreign topic for me. And so a lot of this, I'm just like, okay, how do I even approach some of these topics? But okay, so I have 5 kids and my youngest is 6 now and my oldest is 14. So 14 years ago, when we had our first baby, almost 15 years ago, we were in Houston, Texas, and the doctor approached us about whether or not they just asked us and offered if we wanted to capture the cord blood. So you want to harvest the cord blood, save it. We can do that for you. Here's the kits. Like it's like kind of new where they were starting to do like cord blood registry and all that. And I kind of didn't, I mean, obviously this was 15 years ago and I didn't think much of it outside of this is really expensive. I hope it's worth it. And we ended up doing that for all of our kids. And they kind of told us why and what it was for. And I'm like, okay, well, can I afford it? It was really tight, but I was like, we'll make it work. It kind of felt like a bit of an insurance policy to me. So even to this day, I still don't even know if and how I would use those stem cells that we've been paying annually for. Like we have an annual charge to keep those things like
make sure they stay frozen.
At some facility that's protected and all that. But do you have a take on that? Like harvesting, like when you have like your own kids and being able to harvest like that cord blood and the uses of that, is that kind of in the realm of stuff that you work on or do or
no? Yes and no. So maybe it'll help to kind of define 2 terms. So one term is called autologous, which basically just means it comes from you. So if I take your bone marrow, which has stem cells in it, and then I inject that back into your knee joint, that's an autologous procedure. The tissue and the fluid, the cells came from you and they're going back into you. Then there's allogeneic, which means it came from somebody else. And so that would be like using cord blood from somebody else, or outside the US, they can do culture expansion of, a cell line of mesenchymal stem cells. And then, you fly out there and, Joe Rogan talks about it and then you get it injected back into you and all that stuff. So that comes from a different human and then goes into, you. And so my understanding, and again, I'm not super clear on all of the indications that the cord blood can be used for because I know it's extremely limited. And my understanding is it is really just for blood related issues. So if someone has like a blood cancer, leukemia, something like that, in that the child, obviously as an adult, right, or a teenager, if you have something earlier on, it can be used for that. And then I believe it can be used for blood relatives, but like first degree blood relatives. So like brother, sister, that type of stuff for blood cancers and blood-based things. So my understanding is you can't take that and be like, hey, can I have this injected into my knee joint? Because the regulations around that, I think CBER is the main group that does that, but the FDA is involved a little bit too. But they just don't allow you to take that because it cells from another human and then just go and put that for whatever you want.
So I wonder though, because you use the term autologous, right? Autologous. Is the cord blood the moms or the babies?
Oh, that's a good
Because
question.
if it is the babies, it's probably autologous to them, right?
Yeah.
It's just at a different time in their life where their cells are the healthiest they'll ever be, because that's one of the limitations I think of stem cell, like autologous stem cell therapies. If I'm a 70-year-old guy that hasn't been taking care of myself, the stem cells I'm using from my bone marrow or wherever else they're going to be from me, however I've taken care of myself. So they might not be as effective as the baby version of me, right?
Yes and
I mean,
no. Let's get into this. This is a super fascinating topic to me. So that is the common belief, and there are companies and clinics out there that push that narrative, which is that your stem cells are old, so do not use them. Use somebody else's stem cells that are younger. And again, when you logically think about it, you might think, oh yeah, like that kind of does make sense. But what's super interesting is that there is so much data now in older patients, so over the age of 65, getting either a bone marrow or an adipose, so your fat cells also have stem cells in it, getting either of those procedures and doing exceptionally well.
Yeah.
And so we know that the stem cells in older patients will work. There's studies showing that if you take bone marrow from an elderly patient and you try to grow them in a lab, like you can do it, like the cells are still very viable. Now, what's interesting is that the cell lines in bone marrow decrease as we age, and they do appear when you do, the very smart people do their testing to know how old something is. The bone marrow cells do seem to kind of undergo that aging process. But what's really interesting is your fat cells don't. So fat from an 80-year-old isn't really that much different from fat from a 20-year-old in terms of stem cell quality. But then where it gets even more interesting is that when you kind of do a head-to-head comparison of bone marrow versus adipose in patients, a lot of the times, like the outcomes are pretty similar, if not near the same. Now, I think there needs to be a lot better studies to try to tease out the nitty-gritty details of that. But it's not as black and white just to say, you're old, your stem cells are old. Don't you want to use somebody else's that's super young?
Also, not even just age, but like when we talk about the health of the individual and using their own stem cells, it's done all the time in like cancer patients. I know this because I have a niece that went through neuroblastoma, and she's a little baby. And that's what they used. They used her own bone marrow to treat her after she had gone through chemo treatments. Yeah. So it's kind of like, if that was true, that like, that there was some, not negative impact, but less effective impact of using your own stem cells if you weren't like the perfect specimen, then why would they use those? And it was highly effective for her. Yeah. She's in full remission right now, and it was a good therapy for her.
Yeah. And something else too. So there's a study that was published recently where this was in patients with knee osteoarthritis, and they did culture expanded stem cells. So they took the stem cells, grew them in a lab into 20, 30 million cells, and then injected those back in. And what they were comparing was culture expanded mesenchymal stem cells that were autologous, so they came from the same patient, versus allogeneic, so they came from a donor, somebody else, which, if I remember correctly, was also young cells, but I'm not 100% sure on that one. And what they showed was that when you get your own cells back, you get better outcomes. And so there's something about your body, either it's your body recognizing it's your own so that it does better when it's, the stem cells are doing its work. But we also know that there is a level of rejection that happens when other cells get put into you. Mm-hmm. The cells, for the most part, kind of can evade the immune system a little bit, but a lot of those cells, when they come from another human, still get cleared out by our immune system because our body, to a degree, recognizes, hey, these are not my own. Mm-hmm. I should start clearing these out. The same way, if you get an organ from somebody, your body wants to reject it, even if it's perfectly matched, because it recognizes it's not my own. And so that just goes back to the question on, okay, do you want to use your own cells or do you want to use somebody else's cells? Well, we've got some data here that says like, hey, maybe your own cells are actually going to do better.
Yeah. And that totally fits in line with what I was told 14 years ago with the kids. Is it was like, they can be used among siblings really effectively, but it's still more effective if it's your own. But they said it's most effective if it's your own, still pretty dang effective if it's like your first, like a sibling, like 100% sibling. And then less effective if it's totally third party, not related, like it's not very effective at all. I mean, maybe there's some advances there, but at least back then that's what I was told. So interesting stuff. I see that back then there's been tons of advances. So you have all these treatment types now, and maybe we can come back to stem cells too. But the first one on my list, which is one you brought up that you did yourself, was PRP, platelet-rich plasma. So I'm just curious, like, how does that work? Maybe tell us a little bit about how that works and who would be good candidates for PRP.
Yeah, so PRP stands for platelet-rich plasma. So what we do is we do a blood draw. So we take somebody's blood, we then spin it super fast in a centrifuge. When you do that, you're going to separate into basically 3 different layers. You're going to get your hematocrit, so that's your like red blood cells. You get what's called a buffy coat, which has your white blood cells and your platelets in it. And then you have plasma. Plasma contains growth factors, but it also contains a whole bunch of other stuff that's just naturally present in our blood. And so when we process it, we take all the plasma with the platelets. We then spin it again because so we've gotten rid of the red blood cells. We take the plasma, spin it again, and now we pack all those platelets down to the bottom of the tube that we spin it in. Then we just take that bottom portion. And so now we have plasma that is rich in platelets. So that's where the name comes from. And so when we then inject this back into a damaged area, so this is inside of a knee joint for knee osteoarthritis or inside of a supraspinatus for a rotator cuff tear or something like that. These platelets, which are these like little cell fragments, they contain growth factors in them. Growth factors are basically just little signaling molecules that help to tell other cells what to do. And so when you inject that PRP in, those platelets are going to release those growth factors over about 7 to 10 days. And that release then stimulates a new healing response. So if you walk out of here, I walk out of here, and I roll my ankle, one of the first things that's going to happen is my platelets in that area of the injury are going to start to release growth factors because that's the initiation of a healing response. Healing response starts with inflammation. Then we get some tissue remodeling as we continue on. And so we're basically tricking the body into going through a new healing response without adding a new injury to that area. And so the body then does what it does best. It sends stem cells to the area. It sends growth factors to the area. It sends nutrients to the area. You get an ingrowth of blood vessels, which are going to deliver more oxygen and nutrients to the area. And then your body tries to, again, heal that area. Now, we don't always get, most of the time, we don't get true regeneration. Like this is not like you've got a rotator cuff tear and you put PRP in and you take an MRI 3 months later and it's gone. But what we consistently see is patients have significant reductions in pain, improvements in range of motion and function, and then like the sport specific stuff that they care about, right? They can golf more, they can play more pickleball, whatever it is. So almost any orthopedic or sports medicine type of injury can respond to PRP. Now, there's a lot of nuances within that, but for the most part, there's just about every condition that can respond to it. And then there's also the nerve conditions. So things like carpal tunnel syndrome or cubital tunnel syndrome at the elbow, those things can also respond to PRP injections.
So I'm assuming you've seen a lot of patients. Any anecdotal, like interesting story based off of PRP where you've seen it just completely help somebody that's...
I'm trying to think of a specific patient. It's pretty common that we are helping patients who have been told the only thing you can do at this point is surgery. There's nothing else that you can do. And PRP gets them back to where they want to be. Now, it may not be perfect, right? A lot of these times it's not zero pain, but it's like, hey, 80, 90% reduction in pain plus getting the activities back that they want to be able to do. That's a relatively consistent thing that we see.
Interesting. I wonder if it would, like, I go back to this hip replacement example. There's still a ton of pain there for this individual, and I'm wondering if PRP would be something to look into for this, just because I don't know if it's posture now, if it's the way that they're walking or what that continues to cause so much pain in that area. But based on the way you explain that, it seems like it would be a pretty solid test case to at least try, before because the other sad reality here is, like, you're dealing in the pain world, right? You're dealing with people with pain.
Yep.
They want to get rid of pain. And a lot of times people especially a lot of doctors are going to prescribe pain medications, which can be also very dangerous as well. So that's where we kind of get into like, okay, can we fix this doing these things without someone getting addicted to pain meds when they have chronic pain issues? So I don't know if this would be a potentially good therapy for someone that's trying to recover from a surgery or something.
And this is a good topic to get into. So the number one thing that I focus on in my clinic, and I believe is the reason that we get such great success, is I'm going to spend an enormous amount of time figuring out why that pain is still there. Because, for example, and I'll come back to the surgery piece because that just gets really more complicated. But if someone comes in with knee osteoarthritis, they got the x-ray from the ortho says you're bone on bone, you need a replacement, and they don't want to do the replacement, and they come see me. If I were to just inject inside the joint, which that's where the arthritis is, right? You've got thinning of the cartilage and you've now got some exposed bone that's rubbing on each other. If I were to just inject inside the joint because they've been given a diagnosis of knee osteoarthritis, that works, and it works in a good chunk of patients. But what really takes this from working in 60 to 70% of patients to 90% of patients is spending the time to listen to their story on where their pain is, what makes it worse, what makes it better, the different things they've tried, how they work, things like that. Then doing a hands-on physical exam where the goal is actually to recreate their pain. So a lot of patients, as an example, who have knee osteoarthritis also have pain coming from at least one of the ligaments around their knee joint. And then there's a nerve on the inside of the knee called the infrapatellar branch of the saphenous nerve that is very frequently involved in the pain aspect of knee osteoarthritis. If you just put PRP inside of the joint, it doesn't treat any ligament, it doesn't treat any tendon, it doesn't treat any nerve that is outside the joint. And so when we go to do injections, we go and inject the specific structures that we found through our diagnostic workup to actually be causing pain. So if I place load into the MCL, the medial collateral ligament, the ligament on the inside of the knee, and that recreates their familiar pain when they go upstairs, and then I test the lateral collateral ligament on the outside of the knee, and that's not painful. I test their patellar tendon, and that's not painful. And then I test their medial meniscus, and that is also painful. So now we've got a few different structures so that when we go in to do the injection, we're treating more comprehensively, and we're actually injecting the structures that are contributing to their pain, which then increases the success rate and patients get a better response out of that. So going over to the surgery example, the number one question is, why is that pain still happening? Because you could have new pain from the incisions. So fascia can become painful as you're cutting through it. Some of the techniques are a little more aggressive on muscle retraction, and so you can have pain associated with that. You can have nerve traction injuries as they're using the retractors to get into the hip, so it can pull on a nerve, and then that nerve is under tension during the surgery, and that can cause chronic pain afterwards. It could be that as they were cutting down through the muscles, a little bit of muscle pulled off afterwards in the rehab process, and so now they've got a new tear. You obviously have all of your implant related things, like you could have, some micro vibrations in the actual implant inside the shaft of the femur that can cause pain. Or it could be a posture related thing where just the change in gait is now placing more load on a different tendon that for majority of life has had this set load, and now it's got this set load. And so now that just becomes tendinotic and painful and stuff like that. So that is so important. And I think if viewers take anything away from this talk, if they're going to go look for somebody who does regenerative injections, it's finding someone who actually cares why you're in pain. And they do that with a physical exam, not just looking at your x-ray or MRI and go, oh yeah, you've got this finding on your MRI, so let's just inject that, because that might not be the cause of the pain.
That's really good. Like that's actually really interesting and important. Even talking about what I appreciate you going through all the different types of damage that can be done as a byproduct of just getting the surgery.
Yeah.
Because I think that that's where a lot of people's pain is probably coming from after surgery, especially the nerve piece seems to it resonates pretty well there. So between, PRP injections, and maybe go back to like stem cell therapy, when do you use one versus the other?
So majority of what we do in our practice is PRP. It's an easier price point for most patients. And so that just is kind of where most people are going to land. But if finances were completely removed and we could choose PRP or stem cell therapy based on condition, there's a few different things that show up in the research. So the first thing, which I find really fascinating, is if you look at some of the research studies that have compared PRP to stem cell therapy for, let's say, knee osteoarthritis, and the study lasts 1 year. Most of the studies that have come out show there's actually no difference in PRP versus stem cell therapy 1 year later. And so when these first studies came out, most of the conventional community was just like, stem cell therapy is a waste of money. It doesn't work. It's no better than PRP. Just go do PRP. But there's now some other studies that have come out that are looking at longer term, effects of PRP and stem cell therapy. And what the data is now starting to show, and we see this in our clinical practice as well, is that for that first year, they're about PRP and stem cells are about the same. But then once you get to year 2, year 3, year 4, year 5, you start to see kind of this like slow regression in the PRP group, and the stem cell therapy continues to hold. So the stem cell therapy seems to last a lot longer than the PRP group. And so that's one of the things that, we'll talk with patients about when they're like, hey, do I do stem or do I do PRP? It really is like, hey, here are kind of the results that we see between PRP and stem. And then we kind of leave the decision up to them at that point. There are some situations where specifically the what's called microfat, which is where we do a mini lipoaspiration. So we take their fat and we just resize it to make it a little bit smaller and get rid of the inflammatory oils and stuff like that. And there's not great studies on this. I'd love to see some really good studies, but myself and a few other docs in the community anecdotally have seen this. If you have a tendon tear, so let's say you've got a partial thickness rotator cuff tear and there's an actual gap there. Now, this is not a full retraction, right? That needs surgery to bring those two pieces back together. But, if you've got a 3, 4, 5 millimeter gap on just one part of the tendon, it makes sense that you would want to fill that gap in. And when you inject fat into that gap, that fat is going to stay there. And the stem cells are with, in between all the fat and everything like that. The fat and stem cells are going to stay there for longer, and they provide a scaffold for healing. Whereas if you do bone marrow, even though it has stem cells, or you do PRP, it's liquid. And so it's going to get absorbed by the blood vessels and the lymphatics really quickly. And so that may be an area where we may say to patients, hey, you should consider doing an adipose procedure because you've got this gap that we want to refill in, over the next year, 2 years as it heals. And then I think the last thing is just the severity. So the more advanced the condition is, the more likely someone's going to need a stem cell procedure over a PRP procedure, just because, the degeneration or the damage is just way more severe. So you need a stronger stimulus in that area. But the other thing I'll comment on is both of these treatments are getting at the same goal, which is restarting a new healing response by the body. And so you can achieve, how do I say this? You can get the same end result. You just might need more PRP treatments to get there compared to a stem cell procedure. And so even if someone can't financially afford a stem cell procedure all up front at one time, they go, but over the next 2 years, I could do this 3 times. Like financially, I can make that work. I just can't do, 3x the cost right now. And so they can get there with PRP. So it's not as black and white on just like, this will only respond to PRP. This will only respond to stem cell therapy. It's kind of like all roads lead to Rome. It's just how you're going to get there.
So is there a point at which it's too late for these treatments and surgery is absolutely the only way to fix a problem, or do the regenerative properties of these actually grow enough tissue to be able to avoid surgery completely for like rotator cuff type issues? I just seems to be that you hear doctors just say, yeah, you're past the point of like any type of therapeutics. We have to, do surgery on your rotator cuff or your knee or your hip or whatever.
Yeah, there are. I mean, the very, 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 very end stage of every orthopedic condition is probably going to do better with surgery, especially if it's a joint and its replacement. So, for example, I had a potential patient. This was probably about a year ago. She wanted to see about doing stem cell therapy with me, and this was the worst hip I've ever seen on an X-ray and an MRI. And I said, look, if you are like, I'll die with this, or like I'm not going to do surgery and I'll die with this. Like if that's your mindset, like I'll do a procedure, but it might only give you 50% relief for 6 months and then you'll have to do it again. I think you should just go get the replacement. And she actually ended up getting the replacement and reached out to us afterwards and like thanked us for telling her to go get the replacement. Now I have had other grade 4 or end stage hip OA patients that weren't as bad as her that we did do stem cell procedures on, and those patients have done really well. We've done quite a number of cases of stage 4 knee OA that have done really well. So it can, but what we notice is that as the disease progresses, less patients will respond. So if you have grade 1 knee OA, 90% of patients are going to respond. Grade 2 might be 80. Grade 3 might be 60. Grade 4 might be 30. So it can still work, but it's just working in less people. Mm-hmm. And so that's one of the things we'll talk about with patients is like, our success rates will go down as we get more advanced, but there's still an opportunity that it could be helpful for you. The other things that require surgery, in my opinion, is obviously any fully torn tendon or ligament where there is retraction. So again, you have a supraspinatus tear and the MRI shows that tendon is literally 1 centimeter apart. No amount of stem cell therapy with our current technology, maybe something in the future for sure, but with our current technology, this has snapped back, right? And so you need a surgeon to come in and physically grab this and physically move it over and physically tie it back together. Those are things where, surgery is needed. And then there's starting to be some emerging evidence that the surgeon can combine stem cell therapy or PRP at the time of surgery and actually help improve the outcomes from that surgery. So I think where this field will progress to is, I think there's going to be, in 10 years, I think there's going to be a lot less surgery because I think orthobiologics and regenerative medicine are going to fill a gap before surgery. And I think the surgeries that are done, majority of them will also have orthobiologics in with them.
That's cool. So you say orthobiologics, just want to make sure I get this right. So you're basically saying like after surgery, these will be used to treat the recovery process. Was that right?
No, like at time of surgery.
At time of surgery, they're using it with the surgery.
Yes.
Okay.
So like if a patient gets a rotator cuff repair, then you can inject into that supraspinatus tendon with bone marrow, or maybe in the future it's called culture expanded cells directly into where they sutured and near the bone tendon interface. So that way there's now a better healing response of the tissue from that surgery.
Is it rare that people are doing that right now? It seems like it would be kind of a no-brainer to do that immediately on every surgery.
There's a lot of resistance in the conventional world for PRP and stem cell therapy.
Just because they don't think it's effective or it's a waste or?
Yes. And this happened, we need a changing of the guard, right? And this happens like we see this in other areas, but we need the old timers to go, and the kids who are coming out of residency and fellowship right now, once they're, really established and they're the predominant market, then that's when it's going to be like more mainstream to really do it. The hard thing though is that insurance isn't covering it, even when it's done during surgery. So, you are going to have a lot of patients who can't afford the extra, $1,500 for their surgery to get PRP in it, or an extra $5,000 for stem cells, or whatever that cost is for them. And hopefully at some point insurance does start to reimburse. It's just, there's lots of data in knee osteoarthritis. It blows my mind and makes absolutely no sense that PRP is not covered by insurance for knee osteoarthritis, because the data is so good. There's even some really great data out of France on knee osteoarthritis and bone marrow stem cells that has shown that it helps patients avoid a knee replacement, which, again, it blows my mind that insurance isn't covering it, because when you look at the dollar amount, like avoiding a knee replacement for an insurance company, like that puts money back in their own pocket by not having to do that. So, and insurance operates on, a P&L. And so what do they care about is spending less money. So eventually it'll get there, but there is a lot of resistance in the orthopedic community, just because there isn't enough high-level studies, in their opinion, because they won't look at anything less than a level 1 double-blind randomized placebo-controlled trial, right? And that's just a group of them. There's definitely a group out there who are open to new ideas and taking that on. But, I have a few friends who are kind of coming out of sports medicine fellowships and orthopedic fellowships, and it's starting to be taught more, and they're learning it in fellowship, and they're doing PRP injections in fellowship and stuff like that. And so I think it's just a changing of the guard needs to happen.
So even today, like if I wanted that and insurance doesn't cover it, but let's say I wanted to pay for it, that's something I could request at time, like when I'm getting my consultation with a surgeon on some procedure. You
would have to search out a surgeon who does it. You wouldn't just be able to go to the surgeon that your insurance says, hey, this is who we cover, and then you go to them and then say, hey, can I get PRP? Because if they're not bought into it, then they won't have the rep, they won't have the kits, they won't have the system, they won't have a way to bill it. Like there's so many things that go into adding that service in. And so it comes down to just if you needed surgery, to do the research on, okay, who does add PRP or bone marrow into the surgery in the Valley, and then work with them.
Do you have contacts with people around here that would do it?
There's a few that I know, yeah.
Okay. So I think maybe a step for people, if they really wanted to, is probably to find someone like yourself that's whether they're in their local market or whatever, that does regenerative medicine, naturopathic, and try to get a referral somewhere. So I don't know how else you'd find that individual that offers it,
I think if you Google search, I think it'd be relatively easy to find, because usually what will happen is these orthopedic surgeons will also in their office do PRP injections.
Okay.
So if you can find an orthopedic surgeon who does PRP injections for knee OA, but they also do knee replacements, then it's more likely that they would add PRP into their surgery if it was indicated.
Okay. Well, that's cool, man. I'm learning a ton about this stuff. Any controversial, before we move on from stem cell, any controversial takes on it, why people might avoid it, the kind of scare tactics around it, common concerns that come up for you with people?
Yeah, I think one of the big things is, I've talked to several people over the years where their kind of first objection to stem cell therapy is, well, my cousin Sue had it and it didn't work for her. And so then they assume that it's not going to work for them. And the majority of people out there who are injecting PRP and stem cell therapy do not try to figure out what's causing patients pain, what I talked about earlier, right? They just go, oh, you've got knee osteoarthritis, we're going to inject it inside your knee joint. Oh, you've got hip arthritis, it's just going inside the hip joint. And so if you put it inside an area that your brain is not perceiving as painful, or it's not the majority thing that's causing pain, then you're not going to see a response. And so I think that's probably one of the biggest, obviously the financial objection, but I think the biggest objection that I've heard outside of that is, well, my cousin Sally, my brother Joe, whoever, somebody else had it and it didn't work for them. How's it going to work for me or something like that?
Yeah, I could see that. I mean, it is expensive. They're expensive treatments and you don't want to waste your money. And it is kind of a guess as to whether or not it'd work. But I think to give yourself the best chance possible, to your point, is it'd be a bit of a red flag if they just said, okay, based on this x-ray, this is where the issue is. We're going to inject right there.
Yep.
I think what you're saying is make sure the individual you talk to does a physical exam to make sure they know where all the pain points are, because the pain could be coming from a different area of your body.
Correct.
Yeah.
Yeah.
Cool. No, that's great advice.
I'll add another red flag if people are looking for a provider is you want to make sure someone is using image guidance for the actual injections. Yeah. So this is ultrasound and or x-ray. And it'll kind of depend on what you're treating. If you're treating something deep in the spine, it's got to be x-ray. If you're doing tendons, ligaments, nerves, then it has to be ultrasound. There are a lot of docs out there who still practice what's called palpation guided injections or blind injections, where they just, feel on your elbow and you go, oh yeah, that's where my pain is. And then they just put a needle right down in that spot. And that can work for a chunk of people. But again, if you want to go from 60, 70% success rate to 80, 90% success rate and add a layer of safety in, right, then you want to add in, x-ray and or ultrasound. But definitely ultrasound if it's anything soft tissue related, a rotator cuff, a ligament, something like that.
Cool. No, that's good advice. So the other thing I wrote down here, which was one you sent to me and I'd never heard of it before. So I'm going to need you to educate me on what nerve hydrodissection is.
Yeah, you got it right.
Did I say it right?
You did.
Right. So yeah,
nice.
What is that? Honestly, I have no idea what this is and what kind of symptoms or conditions it helps.
Yeah. So nerve hydrodissection is a technique where under ultrasound guidance, we will locate a nerve that is either irritated, inflamed, or compressed. So it's entrapped. And we will inject fluid around that nerve with the goal of doing two things. The first thing is we are actually mechanically decompressing this nerve. So when we inject that fluid around the nerve, we are creating a halo of fluid around that nerve, which lifts the fascia and the muscles and maybe a ligament or whatever is compressing down on that nerve. And so you kind of get the nerve gets to breathe a little bit. Now, it's not a surgical decompression, so that effect is not permanent. Eventually your body absorbs that fluid and the tissues will come back down around that nerve. But even if you did that injection with something that has no medicinal therapeutic benefit, like just water, there still seems to be a lasting benefit to doing that. So there's something special about temporarily decompressing it, letting that nerve have better axon flow, better blood flow, better lymph flow. And then even if that water goes away, there still seem to be some lasting improvements. But then the second thing that we get out of that is we get to bathe the nerve in whatever we're injecting. And so if that's PRP, or if it's a variant of PRP called platelet lysate, where we break open the platelets and we basically get an instant release growth factor solution as opposed to that slow release growth factor solution. Or we're doing stem cell therapy, or we're doing dextrose, which is just sugar. That actually is calming to irritated nerves. And so you get to bathe the nerve in this fluid that then helps the nerve to heal, repair, and regenerate. So the conditions that are going to do best with this are your typical compression neuropathies. So you can think of carpal tunnel syndrome. You've got cubital tunnel syndrome in the ankle. You've got tarsal tunnel syndrome. And then their thoracic outlet syndrome is another good one that, patients can have good response to. So basically anytime that you've got nerve pain that is coming from a friction nerve, an irritated nerve, a compressed nerve, that's where we would use a nerve hydrodissection.
Okay, cool. So, I mean, it's similar to the other two as far as like trying to relieve pain specific to nerves.
Yes.
But it's almost like you could do this. This could be a type of PRP treatment as well.
Yes.
What it sounds like. So if you use PRP, it's probably going to be the PRP expense. If you're using sugar, I would assume it might be a less expensive treatment.
Yep.
Okay. So it's probably just depending on whatever the fluid is you're using.
Correct. Yeah. Yeah. And that's a good distinction, because there are within regenerative medicine, there's techniques and then there's solutions. Mm-hmm. And PRP is kind of this weird one where it is technically the solution, but people call it that as the technique. But in reality, when we do an injection with PRP for a tendon or ligament, we're technically actually doing what's called prolotherapy, which just stands for proliferative therapy. And that's the technique that we go into a ligament, we inject into the ligament in order to help the cells proliferate and to repair. Mm-hmm. And so, there's one clinic out in Florida that what they do is they call it PRP prolotherapy or stem cell prolotherapy. And we don't do that because I think it just gets confusing. So we still just call it PRP. But yes, PRP is the solution. But if you were to go get a PRP injection, typically people are going to refer to like into a joint or into a ligament or something like that. And then we've got nerve hydrodissection, which is a technique that we can use sugar, we can use PRP, we can use stem cell therapy for that injection.
Do you ever use other just peptides for some of these injections, or for these types of things, or is that completely separate?
We have in the past. This was probably because it was before all the FDA stuff. This was probably 2018. We were doing like hydrodissections and joint injections and stuff like that with, BPC or cerebrolysin and stuff like that. They were helpful, but PRP just did way, way, way better than the peptide injections. And so probably after doing it for about a year, and again, that was interspersed with PRP injections, right? We were testing everything out and seeing if there was a patient population that would respond really well to it. And again, most patients still got better, but when I looked at how well other patients did who got PRP instead, PRP blows it out of the water, and peptides aren't cheap. Right. And so you've got the overhead cost of actually purchasing the peptide. And so it just made sense for us to just continue honing in on our PRP.
Yeah. Curious about BPC though, because obviously the injectable has its FDA issues. And I don't know if you have an opinion on peptides being labeled, high risk by the FDA in many of these cases. I would love your opinion on that. And then also one question I actually asked you on your page, because you were posting about BPC, and maybe what is it used for? It's a pretty hot topic, right? You see BPC getting thrown out all the time. Yeah. People are talking about it. Lots of anecdotal data. People seem to think like, man, like muscle issues, or like, I think it's more for a lot of like the minor stuff that we deal with, whether it's like I just kind of like kinked something at the gym and I've had this like little ache in my arm for a while. I've seen it like more like joint and tissue, like repair on a smaller level maybe. But the injectable, like at the site of pain versus injection anywhere versus oral. So like just an oral supplementation, taking it orally. Is there any difference in its efficacy from what you've seen?
That's a great question. So every animal study that I have looked at, and I'm sure there's some that I haven't seen, but every animal study that I've looked at where they do different routes of administration. So they either put it in the drinking water, so that's the oral form. They inject it directly on or around the injured tissue, or they do it in like a peritoneal injection, which is a little bit in between an IV and a sub-Q in humans, but basically it's getting it into the bloodstream. There's never been a difference between any route of administration in any of the animal studies. Now, we don't have human data on that. And so we don't know what is the difference between doing it intravenous versus sub-Q versus IM versus oral versus directly into the joint. We don't really know. Clinically, though, what I've seen is that in majority of people, 90-95% of people, oral and sub-Q work basically the same. And it doesn't matter if it's a gut condition or if it's a musculoskeletal condition. Because again, there's a lot of big influence out there who are pushing that BPC oral is for your gut because it doesn't get absorbed. It just heals your gut. And the sub-Q is only for your muscles and tendons and joints because that goes in your bloodstream. So how could it help your gut? And I'm like, have you ever actually worked with anybody? Have you ever actually given BPC to people and seen how profound it can help? Even, when you do sub-Q and it helps their gut, or you do oral and it helps musculoskeletal, like it's crazy. So, and there was a small study that was published about 5 years ago now. They did intra-articular injection with BPC and patients got better, but there's no placebo. There's no, it wasn't a large study or anything like that. And so I don't know if it really matters the way you deliver it. I think what matters is just that you do it.
So with BPC as kind of just a topic, it got removed from availability from compound pharmacies and others to make it. And for guys like you to be able to buy it and inject it as a therapeutic for patients. Just what are your thoughts on that? And did you see any adverse reactions to it in your practice when you were using it, or?
So we've been using BPC for 7 years now. So it was the start of 2018 when we first started using it. So actually almost 8 years. And in that entire time, and we've given a lot of BPC between my wife and I, we have had one patient who had constipation after starting oral BPC, and it resolved within 72 hours of stopping. That's
just constipation.
Just constipation. That's the only thing we've seen.
So why the FDA lock this thing up?
Oh. How deep can we get on this podcast?
Conspiracies. We can get as deep as you want, man. You got an appointment though.
I think I'm good for a bit. I think it is. I think it all comes down to control and money. At the end of the day. Now, so the FDA has right now been going around and they've shut down 2 research chemical websites. I don't know if you were aware of that, but I think that's a good thing. And also just heard last week that Health Canada is also going around and shutting down the research chemical websites. And so,
meaning the people that are trying to sell it as like a research only, not for human consumption.
Yeah, it's like you go on, peptidepiances.com.
It's sketchy stuff because, there's other ones out there like the growth hormone ones like CJC up in Moreland. I had a friend of mine reach out and her high school son is like wanting to buy this stuff off a website. And I'm just thinking like how many, and this kid comes from a good, smart family where they don't do dumb stuff like this. And he's like really pushing them on it. And I'm thinking like, how many people are buying this stuff and injecting themselves with highly questionable solutions?
So we've had a number of patients come to us who have taken BPC, because that's kind of the main one that people will take, mainly BPC, sometimes the growth hormone secretagogues, from a research chemical website. They had a side effect, a reaction to it. And so when I talk about like, hey, okay, we're going to start you on BPC, they're like, oh no, I can't take it. Like I get side effects. And I'm like, you probably don't. So what happens there is that because, and I mean, I'm assuming you've been inside Strive and you know what it looks like to actually make something sterile. Yeah. It's not just like you open everything up on your kitchen counter and you make it, right? So there's a level of sterility that is required in order to really guarantee that these products are safe for being injected and bypassing one of your immune systems, which one is your skin, but 2 is also your gut. And so these research chemical websites don't go that extra mile to make sure that there's no bacterial endotoxins or contaminants that are present in their vials, which is why they can charge a lot less money because they don't have all that overhead to do all that extra stuff. And then people end up having reactions and then they go, I got a side effect from BPC. And it was it's more than likely 99% not a side effect from BPC. So I had one guy who came to me and he's like, hey, I think I'm having a reaction to BPC that I bought online. Or sorry, no, he said, I'm having a reaction. I think it's to the bacteriostatic water. I think I'm allergic to bacteriostatic water, which is just water that obviously it's sterile. So it's sterile water that just has a preservative in it. So that way it doesn't grow bacteria once the vial has been pierced. And I go, no, you bought it off a research chemical website. It's probably there's bacterial endotoxins. It's like, no, I think it's the bacteriostatic water. I go, okay, how about this? I'll sell you one of my bottles of bacteriostatic water that's like from a pharmacy, and we'll do a sub-Q injection on you, and we'll see what happens. And so gave him the bottle. He comes back a week later. He goes, yeah, it was the BPC. He had no reaction to the bacteriostatic water. He was having a reaction to something that was present in this research chemical peptide. And so we switched him on to injectable from compounded. He had absolutely no issues.
Yeah.
So,
yeah, I mean, these compound pharmacies, there's a few great ones, but they spend a ton of money in the sterility, but also in the testing of all of these too.
Yeah.
And they get FDA, they've got the state regulatory people just drop in all the time. They're constantly being tested, probably tested far more than big pharma is with their commercial facilities. So they've got a watchful eye on them all the time, and they spend a lot of money making sure that they are completely safe and in line with what they say they are, so it makes me nervous. There's a ton of people buying this crap online, specifically kids. Like, I mean, once you turn 18, you're still a kid, in my opinion. Turn 18, you can do whatever you want, I guess. But seems like there's a pretty sizable risk to just go on and buy these research chemicals off a quote peptide website, especially when you're talking about, potential growth hormone type peptides that could really mess up with someone's development.
Yep.
And
I agree.
Else. So anyway, well, this was all all interesting. I could talk about peptides forever. We just kind of got to the end there and just briefly touched on peptides. It would be kind of cool if there was a time we could have you come back and maybe we could go into I think peptides are pretty interesting. Mm-hmm. And I do feel personally that they could play a big role in the future of medicine. I'm also really hopeful that this BPC thing is going to resolve itself with the FDA. I mean, with this administration, it seems like at least the Bobby Kennedy side of things, he's got a lot of compound pharmacies and pretty influential, people that are in this space, MDs and others that are showing, he just seems to be a proponent of it. So the fact that you've got someone in there that has used functional medicine, regenerative medicine, peptide treatments and all this stuff in the past and seems to be has been like really helpful for him and others. And he's kind of in charge. Gives me a little bit of hope that there could be some loosening of that so that it's not such a controlled money grab for some. But it gives more access to all of us that could really benefit from it so much with something that's safe.
And then hopefully it drives down the price.
Yeah.
Because there's competition 100%. In the market, because that would be hugely helpful for patients in getting access.
But the unintended consequence is then you have the research chemical places that pop up and they're selling a bunch of crap. Yep. So that's the flip side is you get like this black market. It's like, just make sure it's regulated, make sure it's sterile, make sure it's good, drive the cost down. Competition breeds efficiency. We all benefit. Yes. So hopefully that happens. But man, thanks for coming in. You're super smart. Maybe for our audience, just let them know, maybe tell us where they can find you if they want to follow along with what you have or want to reach out to you here locally to come in and get checked out. Where can people find you?
Yeah. So on Instagram, at Dr. Drew Timmermans ND, I think. I always forget what it is, but if you search me, you'll find me. And then I have a lot of videos on YouTube. And so I love sending people to YouTube. I think at this point I've got like 1,600 videos. So you can search my channel for what you've got going on, what you're interested in. And there's a ton of videos. So if you just search Drew Timmermans, you'll find me.
Awesome, man. Well, thanks so much for coming in. Really
Thanks for having me,
it.
Colby.
Okay, cool.